And now, we bring you the following live press announcement from D.C. Mayor Muriel Bowser. Our regularly scheduled program will resume following the announcement.
Good morning. I'm Muriel Bowser. I'm the mayor of Washington, D.C., and today I am providing a situational update on the district's response to COVID-19, and I will share information about the first steps we are taking as part of a phased reopening. Let me start with reporting new case information in Washington, D.C. We reported this morning 72 new cases of COVID-19, bringing the number of people confirmed to 8,406. Sadly, we also reported that 5 Washingtonians lost their lives to the virus, bringing the number of people lost to this virus to 445. We also shared that with today's report, we have 14 days of sustained decline in community transmission. Of course, this 14-day decline in community spread was one of the metrics we established for moving into phase 1. And now we have reached it along with other metrics for testing capacity, healthcare system capacity, and public system capacity related to testing and tracing. Yesterday, we also announced that we are opening 2 new testing sites. And as we begin to have more people moving around the city, I want to emphasize that we have the ability to test anyone who needs a test. So if you need a test because you are sick or because you have been exposed to COVID-19, we're asking you to call your doctor or to call one of our citywide testing line to get a test. If you need a test, get a test. And we are also want to make clear that there is, in addition to our city-supported sites, your providers and hospital systems around the district have capacity of up to 5,500 people per day. So if you have a symptom or exposure, call your doctor. If your doctor can't test you, call us. We will be also opening on Monday a new testing site downtown. It will be a walk-up testing site on F Street between 4th and 5th Streets. I think we slightly adjusted the location. It will be open on Monday on F Street between 4th and 5th Streets. We also know that later this week, CVS will be announcing that it will offer drive-through testing at several locations in Washington, D.C. This will be self-swab testing for COVID-19. So look out for an announcement from CVS this week. The bottom line and what we want to emphasize is that this virus is still in our city and in our region and in our country. We still need to be very focused on identifying who has COVID-19 or who has been exposed to COVID-19 and making sure those people isolate so that we can stop the spread of the virus in our city. Testing is how we do that, and we know that more people will be moving around, and we want to emphasize to everyone, if you need a test, get a test. So today I will be signing a mayor's order that will lift the stay-at-home order. Beginning Friday, May 29th, we will move into phase 1 of reopening. So I want to clarify this. COVID-19 is still in our community, in our region, in our nation, and the public health emergency will continue. Gatherings of more than 10 people are still prohibited. And I want to make sure we all understand that moving into phase 1 means that more people can get infected because now more people will be moving around in the community. We have put in place the hospital capacity, built up our PPE supply, and added new contact tracers so that we are ready to overcome what lies ahead. But we know without a vaccine or a cure that we will see new infections. So as we begin reopening, it cannot be said enough that every single one of us has a role to play in protecting ourselves and each other. It's critical that people wear masks, social distance, and continue to practice good hygiene. We have a shared responsibility to stop the spread of the virus even as we reopen. We also have a special responsibility to protect those who are vulnerable because of age, underlying conditions, or health disparities. By taking these responsibilities seriously, we can continue to make progress and move toward getting our kids back to school and people back to work. If we don't take them seriously, we risk losing the progress we've made by our shared sacrifice. So now let's talk about what is changing in phase 1. Retail. I'll start with talking about retail. Non-essential retail businesses can now operate with curbside or front door pickup. This is new. So customers can call these retailers and order online or over the phone and pick up their items curbside or at the front door. You may continue to deliver items ordered online or on the phone, but no customers may enter your building. No customers may enter your establishment. Barber shops and salons are going to be able to open by appointment only. Workstations will need to be 6 feet apart, and the services that can be offered are limited to hair services. I know that many people are eager to get their hair done, but we want you to remember also to do your part to keep yourself and your stylist or barber safe. And certainly do not go to your appointment if you are sick. There is no waiting allowed inside the shop, and shop owners may have 1 customer per licensed barber or stylist. There is no waxing, threading, or nail care allowed. Restaurants. This is another industry that we know many people are eager to see safely add options. So in addition to takeout and delivery and grab and go that restaurants have been providing throughout this pandemic, we are now allowing outdoor diners. So diners may be seated outside, and customers must place their orders and be served while seated. All tables must be at least 6 feet apart, and no more than 6 people can sit at a table. For restaurants that are not currently permitted for outdoor seating, we'll be working with you to see how to make that possible, and I will share more about that in a moment. But we're launching a process to reimagine sidewalks, roads, and other spaces for restaurants, retail, and recreation. Let's move on to parks and recreation, and I'm talking about the parks operated by DC government, and these parks have been closed, in some cases locked, and they will be unlocked and able to be used. And you can see that the passive parks can be used: dog parks, golf courses, tennis courts, tracks, and fields. We are not able to open at this time playgrounds, public schools, recreation centers, or other indoor facilities at DC Parks and Recreation. We are also not able to permit or allow contact sports. In contact sports like soccer, basketball, and football, of course, inherent in them is a level of contact that makes it much easier for the virus to spread. Additionally, we are working to identify places around the city where we can use streets, alleys, and sidewalks to create more space for restaurants, retail, and recreation. I've tasked my special events task force that is housed at HCMA in conjunction with the District Department of Transportation to lead this effort. 20 to 30 DC government agencies participate in the Special Events Task Force, and their job throughout the year is to make sure that road closures are safe. So we will be working and have more to say about that. Next, let me talk about elective surgeries. Actually, I'm going to ask Dr. Nesbitt to talk about this. What we outline in our mayor's order during phase 1 is that healthcare providers may continue to offer or resume offering outpatient or other surgical procedures that will not unduly burden our hospital capacity related to COVID-19 resources. And DC Health, along with other topics, is making guidance available about this topic. But Dr. Nesbitt, would you add to what I've said?
Sure. And I believe the mayor is going to highlight some of the very specific guidance documents that DC Health has worked to produce. But in particular, there will be guidance documents made available to healthcare providers, which includes the dental healthcare provider community, that provide some guidance as to what procedures or what types of healthcare services we suggest should be offered in phase 1. As the district's healthcare regulatory agency, we do not opine on the specific healthcare procedures, meaning that we are not giving a list of elective surgeries, meaning saying hip replacements versus vascular surgeries, et cetera, but leaving it to the discretion of the healthcare professional who is doing the clinical assessment of the patient to make that determination. The guidance that we provide suggests to, for example, the dental healthcare provider to take into consideration the amounts of personal protective equipment they have, the structure of their office, the support staff that they have available, to make assessments to their patients to determine what services could be provided using teledentistry, what services require a face-to-face visit, and what services within the types of equipment that they have available could be done with limited risk to the patient and their staff, and also without burdening the COVID-19 related resources in our community. Similarly, our hospitals and our ambulatory surgical facilities in the district will be making assessments to determine what types of medical and surgical procedures can be offered to patients that may have no requirement for hospitalizations or may have short stay hospitalizations, to ensure that we can continue to have a level of hospital capacity in the district that will allow us to rapidly and quickly respond to any potential medical surge that could happen as we move into phase 1. Thank you, Mayor.
Thank you, Dr. Nesbitt. As Dr. Nesbitt mentioned, her team has also been working on additional guidance that relate to phase 1 reopening, including for barbershops and hair salons, child care centers, dentists, elective surgeries, as she's just mentioned, for people with chronic health conditions, for older adults, parks and open spaces, restaurants, rideshare operators, and for schools. So please refer to those guidances that will make more clear some of the information that's included in the mayor's order. All of these guidances and the mayor's order can be found at coronavirusdc.gov/phase 1. Finally, let me just say that when you think about entering phase one, what you should be thinking about is that, and in my mind, I actually call it stay-at-home light. It means that the stay-at-home restriction has been lifted, and some activities have been added back to what we can do, but they're minimal. So you can go to a restaurant and dine outside. You can go to a retailer and pick up from the curbside. You can go enjoy more public park space. But we continue to ask you to be mindful of not gathering in large groups because they are prohibited over 10. When you are around family and friends, that you're using a mask, that you're careful about being around people with pre-existing conditions or older adults, that you are taking very seriously hand washing, and that you're taking very seriously listening to your body and recognizing when you are sick and not going out. And making sure that you're getting a test if you need a test, and consulting with your doctor or coronavirus.dc.com for testing locations. So I'm joined by Jennifer Smith, Chris Rodriguez, and Chris Geltard, along with Dr. Nesbitt. Are there any questions? Yes, ma'am.
Before you implemented the stay-at-home order, you were telling DC residents not to spend time with people outside of their household. Now that you're lifting it, can you explain what the approach is for seeing people outside of your household here? Is that allowed now?
Sure. Dr. Nesbitt, if I could ask you to speak to that.
Sure. So in addition to the guidance documents that have been highlighted, we are still encouraging people to be very prudent in terms of socializing outside of their household unit. As the mayor has articulated, gatherings of groups larger than 10 are still not permitted in the District of Columbia. As the stay-at-home order, as the mayor has mentioned, stay-at-home light is being replaced with the mayor's order today, we still want people to be judicious around the types of activities that they are participating in. It is still favorable for us as a city if people focus on participating in the essential activities that they have previously been engaging in, and using good judgment when utilizing the non-essential activities that have been highlighted today. You should keep in mind that if you are going to be engaging with non-household members or visiting people outside of your household, that some of those individuals may be members of high-risk groups. And so the number of non-essential activities and types of non-essential activities that you participate in may pose a risk to someone else who is part of a vulnerable population. And so you should keep that in mind, that the number of exposures that you create for yourself may put that other person at risk. So if you are going to a number of different venues throughout the day, not properly social distancing, and then visiting seniors, grandparents, individuals with chronic health conditions, it could be detrimental to their health, even if they are remaining at home. So we really want people to be mindful and cognizant of that. We do have guidance documents for families with children, in addition to the seniors, and we have guidance documents for the general public. We advise you all to review those and would ask that people govern themselves accordingly.
Yes, Sam.
Other than, I guess, police stations, I can't think of an area of D.C. government you can walk into. Does any of that change? Is there any area of D.C. government other than a police station that you can walk into and expect some kind of service? And what are the criteria for moving from phase one to phase two?
So, we have about 40% of DC government workers who are reporting to work, and right off the top of my head, I can't think of any walk-in services, but somebody can remind me. You are right that a lot of our services have been shifted to virtual services, including DMV. Some people, I think, are still coming to DOH for vital records. So there are some that are listed on our website that have been modified. We have not changed our telework posture, and there may be some directors or some services that more people are needed as we reopen, and so they will be called in. But at large, we haven't changed our telework posture. And Dr. Nesbitt will talk about probably later in the week. We will post the next set of gated criteria, and then I think they're largely the same, and we'll establish goals related to that.
Any recommendations to, let's say, the federal government as far as what it should do in terms of its workers?
We continue to encourage telework during phase 1, not just for the government, but for private employers as well. So telework continues to be encouraged for all those who can telework. Yes.
Mayor Bowser, do you have any criteria that would trigger the return of the stay-at-home order or all the restrictions that we're currently under?
Well, we will continue to monitor, and DOH will continue to monitor the spread of the disease, of the virus in the district, and this order can be turned up or turned down, or there could be activities that we note need to be changed, and we can change it by order.
But do you have, like, are you going to lay out to the public specific criteria? Like, if we have another 14 days of increased community spread, we'll go back to our current posture?
I don't anticipate going back. What do you mean when you say current posture? The stay-at-home order?
Stay-at-home, the non-essential business closures. Are there certain areas where we could go back to what we're experiencing right now?
I more see if we had to go back, different activities that are listed in the current stay-at-home order, but that could change. Yes.
So Northern Virginia seems to be moving in the same direction. They're probably going to be reopening during the first phase of reopening around the same timeline. Montgomery County and Prince George's County, those could be delayed a little bit. Are you at all concerned about folks from Montgomery County seeing, hey, listen, DC is open, let's head on over the border to get a meal at a restaurant or to kind of go shopping? Is there any concern about that?
I've been concerned about the region. I think you've heard me say previously that I thought it made sense for the region to largely move in step. And I think that will continue to be the case. Regardless of where you go in the region, DC residents should be following, should be social distancing, should be wearing masks, and practicing good hygiene. Yes. Yes, ma'am.
Yeah. So what would you say to individuals who are questioning the methodology behind these metrics and are worried about seeing cases? What would you say to folks who are still nervous about reopening and beginning on Friday?
Well, we know people are nervous. I talk to people every day who are nervous. This is a scary virus, and they should be nervous, and they should be practicing, as we said, continued social distancing where they can, staying 6 feet apart, wearing masks, and practicing good hygiene, and getting tested if they need to get tested.
And just a quick follow-up. For folks who are perhaps questioning the 14-day decrease in community spread and just quite not understanding that, what would you say to those individuals?
Well, we have demonstrated, and we can show the slide again, how 14 days of community spread have been achieved, the vast amounts of data that we have made public for their inspection, and how we have progressed through the metrics we established. Yes.
Mayor, on page 5, section B, phase one additional operations of food establishments. It says taverns, nightclubs, and mixed-use facilities that serve food and that are already approved to provide such outdoor service by ABRA may also operate outdoor dining. What is the difference between that and restaurants? I mean, if it's outdoor dining, it's outdoor dining.
There is no difference if there are foods, if they sell food.
Okay, so I'm thinking of like beer gardens, like there's one on 7th Street, there's one up on Georgia Avenue. If they sell food, they're allowed to open their beer garden?
If they are a food seller where they can seat people, then they can sell food seated, with their patrons being seated.
Okay, following up. You have in here that nail salons cannot open.
That's correct.
Why is that? If they're, you've got barbershops and you've got hair salons that can take appointments, why not nail salons?
That was discussed, and we landed in phase one on services that we thought were essential and needed, especially after 2 months, and provided for less intense contact.
And then my other follow-up is, yesterday you said you're not going to allow any permits for any parades in the city on the 4th of July. Now we're hearing that President Trump wants to go forward with his event on the mall. Does that mean that if they want to put military vehicles down on D.C. streets, that you're not going to allow that to happen?
Well, the Independence Day parade has already been canceled, and that's been several weeks ago.
What if he wants to go forward with his event on the mall?
I'm not sure what event. Are you talking about the fireworks for the National Park Service?
There was a letter put out yesterday by Eleanor Holmes Norton and area lawmakers asking the president not to go forward with his plan for the 4th of July.
I don't know what else another way to say it. The parade has been canceled. Our big concern would be around how to manage fireworks, and we will continue to work with Interior on that. Yes.
Mayor Bowser, what's included in phase one that your that your re-advisory group didn't recommend? For example, I saw dog parks included, and I think the re-advisory group recommended only a limited amount of dog parks reopened.
What was your question? Is are dog parks allowed?
What's included in phase one reopening that you're essential business, or if you're on essential travel? Are those rules going to be expanded for face coverings for when you're doing curbside pickup?
Let me ask Dr. Nesbitt to respond.
It stands as it was last updated. So as you have just stated, it is when you are on essential activities and when you are using mass transit and rideshare, and when social distancing cannot be practiced. We have made some recommendations within the child care and school settings to give further guidance around the use of face masks with children.
But you don't have to wear a mask while you're outdoor dining?
It is not. There is some specific guidance around how to use a face mask while outdoor dining, where we recognize that it is not possible to eat and wear a face mask at the same time, Finnet. But we do provide some guidance in terms of when people are grabbing and going, how we expect them to wear a face mask while they are doing that, if that is helpful for you. Okay.
Mark.
On outdoor seating for restaurants, if the seating is, say, on the roof or in the back, and you have to go through the restaurant dining room to get there, can those restaurants utilize that outdoor space, or is it only sidewalk space where the patrons wouldn't actually have to walk through the restaurant to get to the outdoor space?
I think where we are now, Mark, is that restaurants that are already permitted for outdoor seating, use of the public space, are good to go. But we need to make sure we have a process for the others who are not currently seated for public space. And I don't want to speak to the rooftop just yet, because I want to confirm where we are with that, or if we've been silent on that. But I think we anticipate some incidental going into the restaurant for restrooms, but that's, am I right about that?
Yes, ma'am.
Yes. And did we address going to use stairwells?
So we, to the mayor's previous comment, it has not, with the sanitarians were heavily involved in this process in understanding the layout and where outdoor dining currently exists. It does not anticipate outdoor dining as being broadly defined as the use of rooftops in hotels, et cetera, which is where most of the, as you were describing, the rooftops, rooftop restaurants and hotels. Most restaurants that have outdoor seating, it is either in the back of the restaurant, as you have previously stated, or outside. So every one of them will have an inspection to determine how to use their space and be given guidance on how to use their space. But it is our intention to be as supportive as possible in this process to let them use, as the mayor has described, their previously permitted outdoor seating.
So this is, we're going to need some clarity, and we will, as I mentioned, we're pretty settled on those who are already permitted, and we have some work to do on the rest, and we'll make that clear.
So do restaurants have to go through a process then? If I'm a restaurant that hasn't already, that if I'm a restaurant, do I have to get an inspection before I'm able to open up on Friday and offer seating outside?
An inspection is not required, Mark, but it is going to be necessary to ensure, just like the health department and DCRA works together to make sure that compliance with any of the district's requirements for operating according to whatever the district's requirements are, is to make sure that they are using their outdoor seating and complying with the requirements necessary for phase one, that our restaurants are in compliance with that. So they have been we have all been working very collaboratively together. What we know is that all of our restaurant operators in the district want to make sure that they keep their patrons and their employees safe. So we're going to be working very collaboratively to make sure that everybody understands exactly how this process should be done.
Yes.
So Wabata's hours are different, right? If Metro closes at 9 p.m., I wonder, how are restaurant workers supposed to go back and forth? Maybe there's a partnership that you're thinking about to help workers get to and from their shifts.
And that's a good question, because Metro is committed, as we are, to looking at the phases in ridership and adjusting their schedules throughout all of the phases of reopening. And some of that has included lifeline service. Largely, we've thought about that as supporting hospitals and first responders. But there are other bus and shuttle type services that Metro can flex to per the need throughout the phase reopening.
Question on the public space. This task group, when do you anticipate movement on creating more space for folks to safely social distance?
I expect, and I'm going to get a briefing from the group today who's been working and thinking, certainly, and I expect by Friday we should have a little bit more definition about how so certainly retailers can respond, and restaurants and citizens. Yes.
I wanted to follow up on what Paul was asking about the 4th of July. So President Trump is planning to do his Salute to America event again on the 4th of July, and I was wondering, just to follow up, are you planning on stopping him from holding that event, or how do you plan on responding to that?
We're going to continue to work with the Department of Interior on how they want to use the all of the federal lands, and I don't know what exactly is proposed in the Salute to America. So that will be a discussion we have with Interior.
Mayor Bowser, can I follow up on that? In the past when we've asked you about this, I believe you indicated that you were actually seeking guidance from your general counsel, your lawyer, to see what authority actually you have over this. And I guess the question is, if they go ahead with the fireworks, is there a way, or are you contemplating a way that you would restrict people from coming into the city, much like you did around the tidal basin with the cherry blossoms, just, block the streets that you have control over, coordinate with Metro, and do everything you can to discourage people from coming in, given that come July 4th, if we're still in phase 1, there are probably more than 10 people on the mall for that.
And we're going to continue to work with all of our agencies, including MPD, and have those discussions with Interior. And I am hopeful that we will arrive at a situation that's going to be safest for Washington, D.C. and any visitors. So that's all I can say at this point. Yep.
Question for Dr. Smith. Some weeks ago, we were over at your place as you were demonstrating your mobile testing. Just curious, how's it gone? How many people have you tested? What's the results?
So the mobile testing that we set up, it allows us to put these point-of-care instruments into a truck and drive that truck to a facility. We have focused mainly on our long-term care facilities, the smaller ones where we can do a sampling and testing, actual testing on site of about 40 to 50 people. We have tested about, I believe, 460 folks using the mobile testing capability. I find it very successful. It is sort of an experiment, in other words, of trying to get testing to people who are least likely to be able to either get to their doctor or get to one of our testing sites. So far, so good. And we are working very closely with the various long-term care facilities to make sure we can bring it to them. There is something that we have added, a capability where we not only can do the testing, but we actually now can take folks with us who can go in and help with the sampling. So we expect to be able to utilize that at additional service for some of those facilities that may have not had sufficient staff to assist us with that.
Okay.
Follow up to that question, please.
Okay.
Dr. Smith, you were using these Abbott machines, and there was a question as to whether or not they were giving you the proper results, whether or not you were getting some false negatives there. I asked John Falchecchio about it yesterday. You had done apparently a look-see into whether or not that was happening with those machines?
Yes, so we test every test before we actually put it online. So we had done pre-testing of the Abbotts, and we did a side-by-side comparison of that instrument with our other instruments, and we didn't find this excessively high rate of false negatives. In fact, we found we were getting the same results. When the new guidance came out from the manufacturer, we actually now double test or double swab. So we take 2 swabs, we bring those back, and then we have confirmed that we are getting the same results. Remember, the Abbotts are positive when they're positive. We do call it a presumptive negative, and then we are confirming those negatives with a secondary test.
Mayor, can I just continue? You said basically if you need a test, come in, get one somehow. I guess the question is this. Basically, can anybody that wants a test in D.C. get one?
Yes, if they need it. If they don't need it, I'm not sure why they would want it, but yes.
But if they think they need it.
If they think they need it, they've been exposed, and more people are going to be feeling exposed because they're coming out of their house, or they might find somebody that they know, or they might have been at an event, or they might have been at work, and somebody that they know has been tested who's positive. And so our goal is to, and I can ask Director Geltart to speak a little bit more to this. As we go into phase 1, we recognize that more people are going to be moving around and should get tested. So we will have, as we have done over the last several weeks, we've highlighted several neighborhoods for pop-up testing. We will be adding a downtown location, which we think a lot of workers will take advantage of, that will start start on Monday. We're also moving the Ward 8 location to a more walkable and transit-friendly area in Anacostia. So that's going to be happening. There are now the more commercial opportunities where CVS will be adding these self-swab stations at several locations. And we think also next week we'll be talking about more neighborhood locations for testing. Now, Dr. Nesbitt will be really, really angry with me if I don't also say this, because we not only want people to get tested, we want them to be connected with their healthcare provider. So in addition to the citywide state sites and the hospital sites, you should be consulting with your doctor about how you're feeling, and also utilizing doctors' offices who have the ability to test.
You don't anticipate a situation where somebody comes to a city facility and says, I want to be tested, and they say, no, you don't qualify. You can't get tested.
I would be very disappointed if that happened. And so that is why it has happened, and I know it's happened. And we're going to be working on our protocols to make sure that people who need a test can get a test. Yes, Alex Coma. Alex Coma. Alex?
Can you hear me, Mayor?
Yes, I can hear you.
Sorry about that. Thank you for taking my question. No one really can accuse your administration of not being prudent about reopening, but there have been a number of examples of metrics that have changed over the past few weeks. And I'm wondering how you can explain these shifting parameters. Critics have called it moving of the goalposts, and how much of that is tied to this desire to reopen.
So one metric has changed, and that metric is we talked for some time about following the numbers of cases, reported laboratory results. And DC Health recommended that a better metric to follow was community spread, which includes what the epidemiologists had always follow, and that's with the symptom onset dates. So that metric has changed. We believe that DC Health is in the best position to tell us what's important in monitoring the spread of the virus in the city.
But, Mayor, there's also the question of the positivity rate falling below 5%, which we haven't gotten to. And then there was some criticism of a massaging, and that's my word, of this 14-day sustained decline that we didn't reach, and there was a spike over the weekend, and instead of resetting to zero, it just went back 2 days.
We reached it today, which is what I reported. I also reported yesterday and spoke at length at what changes day to day are statistically important and what would constitute a reset and how that reset would be accommodated. So that's been well explained. And let me say a note about the question of positivity. I think it was reported that we said that we would have a reopening goal focused on positivity, and that's simply not the case. We did report in a meeting that there were some recommended metrics that DC Health was considering that was reported to an advisory group. And DC Health did mention that and talk about it, and it was talked about internally. But the metrics that were recommended to me to follow for reopening never included a positivity goal of 5%. Those metrics for reopening have been consistently discussed since May the 4th, and they haven't changed. Steve Thompson. Steve Thompson.
Hi, this is Steve. Thank you. I wanted to ask about capacity, and I still do. But before I ask about that, and you guys may have answered it in a previous press conference, but I was just looking at the overall testing numbers in the district from a few days ago, and they were reported up to about 52,000, and then they were revised downward down to about 41,000. Can somebody say what the why that revision?
And I do believe that Dr. Nesbitt discussed this over the weekend. And on Saturday morning, we actually reported an overall tested number that was not correct, and it was corrected over the weekend. That number included, overall tested, included all jurisdictions, and so when the non-DC residents were removed, that number became smaller. It also included some DC residents who had multiple tests. So when that was deduped, the number became smaller.
I see. Okay, I understand. Thank you. My capacity question is kind of a two-part question. I know that you mentioned earlier, you mentioned a figure of 5,500 capacity, and I think that was for non-DC directed labs. But I wonder if you could kind of detail sort of where things are on both the public directed labs and the private labs, to the extent you know, as far as the overall lab capacity and the capacity as it relates to particularly reagents, I guess. And then the second part of my question would just be anything that you could say that might build on the trying to close the gap between, and I know we've mentioned many things, including the new testing site and the replacement site at MLK and the CVS drive-through and the mobile testing. But I'm very interested in that topic. So if there's anything that hasn't been said that would be worth saying, I'd be interested to talk about that.
And we expect, Steve, at a future press conference over the next several days, maybe on Monday, to have a longer discussion about testing and all of the things that you just mentioned. So I'm trying to unpack some of your questions that we can address today. So why don't we start with capacity?
So discussions we've had with all of the other laboratories that conduct this testing, mainly laboratories associated with hospitals or healthcare providers, there's about 4,902. There's what the number they've given us for their capacity to do this testing. And then if you add that with our current public health lab capacity, that's where the 5,500 comes from. Additionally, the reagents is very important, and we're always continually looking at the reagent supply. And we are seeing that there are more reagents available, and laboratories have added different types of tests to do. And so the reagents now are becoming more available to do that. It is a community effort, and we are appreciative of the reagents that the federal government is continually helping to supply us. So the 5,500 is the capacity to do the test collectively within the DC area.
And you're able to do all of that now, given the supply of reagents? If 5,500 people came in today, that would be possible to do?
So that is a question that, there's a number of things that feed into that, and that is sampling and as well as testing. So again, when we report our capacity to do a test, we do include the reagent.
Okay.
Okay, I'll come back to you. Thank you, Steve. I'll come back to the room in a second. Tom Sherwood on the phone. Tom Sherwood.
Thank you, Mayor. Thank you very much, Mayor. I have two questions or two subjects, please. On the first are the city streets. Several citizens over the weekend closed their own residential streets to provide walking and play space. What's the city's opinion of this? Is the city going to continue to allow it? And is the city officially considering closing more streets? And I have a question about restaurants to follow up.
So, Tom, I just mentioned that the Special Events Task Force, which includes our DDOT, public safety agencies, to include health and other first responders, are working with the Department of Transportation on some policies around public space and use of public space, specifically for restaurants, retail, and recreation. And I hope that we will be able to say more about that on Friday.
And Mayor, if I can, what about the residents who are closing their own streets?
I'm always concerned about safety, and I don't really know what people are using to close the street, so I would be very concerned about safety.
All right, thank you very much. And then I have a question to follow up Mark Seagraves' question about restaurants. Maybe Dr. Nesbitt would answer this. For the restaurants that already have outside dining space in the back, like ground level open air patios, can the customers walk through a restaurant to get to such outdoor areas in the back?
Well, that question was asked, and I think that we walk into today contemplating public space. We do allow for some incidental walking through of restaurants. I think largely we've been thinking about using the restrooms. So we're going to get some clarity around that, Tom, so everybody is crystal clear. Julie from the Washington Post. Julie?
Hi. Yes, thank you, Mayor. I wanted to ask about this community spread metric, which relies on the date that a person began experiencing symptoms. What date are you counting people who remain asymptomatic and people who you might not know, they might not tell you what day they started experiencing symptoms?
It's a great question. So there's a couple of processes that we use for an individual who we cannot contact. We have a couple of ways to ascertain information about them. The district has very robust participation in a health information exchange called CRISP. So many individuals, their clinical record will be available, and our staff have the ability to review that clinical record and ascertain information from that document that will give us their symptom onset date. Also, based for individuals who are asymptomatic and are presenting for testing based on an exposure, we use what is called the estimated infections period, and they are plotted on the graph with their symptom onset date being estimated as what we call their estimated infectious period, which is 4 days from the sample collection date.
Is there anybody who is not counted in the community spread count because of a lack of information?
The answer to that would be very few. So based on what I just described to you, people who are asymptomatic, we give them an estimated infectious date, which is 4 days from their symptom collection. Anyone who we cannot contact, we use the same process. If we have not been able to ascertain their symptom collection date, symptom onset date from clinical records or an interview.
Alex Coma. Alex?
Hey, this is Alex Coma. Can you hear me?
Hey, I can.
Great. So I wanted to ask a little bit about the section of the order that mentions the information that restaurants should be collecting from patrons. What sort of information should they be taking down from people? How should they compile it? And what will the process look like for potentially sharing that with the district if contact tracing comes up?
I think that all of we kind of leave to them what they're collecting. We wouldn't, I think largely what they collect for reservations would be enough, your name and how we can get in touch with you. But let me go to that point in the order. I think that's it. Do you have anything more in your guidance about that? Okay.
Name and contact information.
We wouldn't, it's not something we want to be overly intrusive or burdensome, administratively burdensome. But what restaurants would want to know is if how to get in touch with people who were there. So when were you there? What's your name and how can we contact you?
That's not mandatory, correct? Is that just recommended? Or
that's recommended. Yes.
On the metrics, for community spread, Dr. Nesbitt, I believe you said during a Sunday press conference that congregate settings weren't included because they're confined spaces and we can put in practices and strategies to address that. I guess I wonder, if they're, workers obviously work at at these settings and they go back into the community, and then also in respect to homeless shelters, individuals staying there don't necessarily always stay there, right? And so I guess can you further explain why these congregate settings are excluded from how you're measuring community spread in this way?
Yeah, so it's a great question. And even as you've highlighted that workers don't live in these facilities and they still go back and forth in between the community and their place of work, it doesn't diminish our ability to put in place infection control practices. So when we talk about these long-term care facilities, detention facilities, homeless shelters that all have employees, in addition to the residents or inmates, whatever the respective facility is that we're talking about, we still have the ability to go in, do a comprehensive assessment, and then make recommendations for infection control practices that can be put in place in that particular facility, which is very different than when members of the general public who have to have a detailed diary of all of their different types of activities related to where their particular infection or known exposure would come from, which is often unknown in a lot of members of the general community, right? General public. So that's what we mean by when there are clusters or cases related to a congregate setting, we can put a lot more focus on what kind of infection control practices can be in place. When we go into a long-term care facility, we make very keen observations around there may still be employees who are working in the quarantine unit and in the non-quarantine unit or the isolation unit and the quarantine unit and mixing, and that is a bad practice. Or we may notice things such as the hand sanitizer doesn't give you an adequate dose to be able to wipe your hands properly with alcohol rub. Or we may notice that people don't don and doff or put on and take off personal protective equipment adequately or wear their face mask properly. So it's that type of assessment of infection control practices that we can do in those types of settings that would allow us, if all of our cases are occurring in those congregate settings, to quickly respond to an outbreak and put measures, controlled measures in place in a much different way that if all of the cases that we were having were happening in the community, we'd be a lot more challenged to be able to respond and decrease or mitigate and contain spread in a community setting. If all of the cases we were having were happening outside as opposed to in these contained settings. It's a great opportunity for us to communicate that we have flu outbreaks that happen in skilled nursing facilities that never reach the community in that same way. Or we may have other types of infectious diseases that happen only in long-term care facilities and don't reach the community because of the types of practices that are happening or failing to happen in those particular settings.
And just my last question. I guess I'm wondering now, so tomorrow, or should we not expect, you released this at 10 a.m., we're meeting like 4 metrics, et cetera. So moving, will it work?
I didn't hear you. I can't hear you.
Yeah, sorry. So every day at 10, right, you release this graph that says we're meeting communities, we're meeting metrics, and I'm wondering what it'll look like tomorrow. Like how are we to know how we're doing?
We'll keep releasing the same information.
So, and then
yes.
I just want to ask about positivity rates one more time. Back in April, Dr. Nesbitt, you said that we were hovering around the 20% positivity rate, and you would like for us to be below 10%. Could you help us explain why you said that then and maybe why you're not saying that as much now?
So let me help you all put positivity rate in context. It is not a helpful measure to keep calculating the total number of tests done in the city, the total number of positive tests we have over the total number of tests done in the city, and calculating your own positivity rate at home. And let me tell you why that's a bad thing to do from a data perspective. And data scientists all over will tell you why. When we first started testing people back in January, we were only testing people who had a travel history to China. The people who we were testing were a very different group of people, very targeted testing. We expected nearly all the people that we were testing to be positive. Very different scenario than who we're testing now, right? So continuing to calculate on an ongoing basis the same numerator over a broad denominator will give you a false sense of what we are expecting or estimating our positivity rate to be, because we are broadening testing. Testing is becoming more widely available. Back in January and February, the only place to send a test was the CDC. Now you can have a test done in a number of places. The state's public health lab, clinical laboratories, private laboratories, and not only private laboratories, a ton of private and regional laboratories. So lots of opportunities for tests to be run in a number of places and lots of opportunities for places to be sampled. It is more prudent to calculate on a rolling basis the positivity rate. So we calculated on a daily basis looking at the number of people sampled on a day versus the number of people who are positive on that day. Some jurisdictions will calculate it on a weekly basis. So you pick a much more truncated period of time that is more consistent with the time frame that you are looking at, that is reflective of what your testing policies are like now. Who are you testing from a broader perspective? Now, there has been a comprehensive review, much different than what we had back in January and February, for positivity rates across the world. What positivity rate have other people observed that says if we get our positivity rate with broad testing across our jurisdiction? Now, is that jurisdiction a city? Is that jurisdiction a state? Is that jurisdiction a country? And what is the population of that jurisdiction, whether it be a city, a state, or a country? What positivity rate has been observed when we can be confident that we won't have a rebound in infections? And that's where these policy recommendations come from. So when we're having these conversations about what is a good positivity rate for us to observe for moving through a phased reopening, it is informed by that type of science. So again, there are some things that the data scientists at the health department, trained epidemiologists and statisticians influence this type of decision making, are reviewing the literature on a rolling and ongoing basis and helping to make these recommendations to us as public health policymakers, who then make recommendations to policymakers. So we have to be prudent in how we are informing our guidance on a phased reopening. So I hope that makes some sense. I hope it gets great context. You can always take numbers and create numerators and denominators, but is it the best way to create numerators and denominators?
Mark?
I've got 4, I think, quick yes or no questions. One, private pools, communal pools at apartments, hotels, condominiums, are they still ordered to be closed? Are they allowed to reopen? You talked about public pools.
Public pools, yes.
Right, but what about at a condo building or a hotel or an apartment building, communal pools?
Closed.
Like that? They're closed?
Yes.
Thank you. And then you said government operations are remaining pretty much as they have been. What about parking restrictions and traffic restrictions that are currently in place?
We haven't changed any of our policies. Is that right, Chris?
That's right. Yes, ma'am.
We haven't changed anything.
Okay. And then at any of these establishments, these restaurants, would they be allowed to offer any type of entertainment at all? I mean, could they have somebody playing a musician on guitar in the corner, entertaining the people at tables? Is that allowed yet?
Let me check, Mark. I haven't. Let me just confirm where we landed with our guidance.
Okay. And my last question is, and I asked about this a few days ago, and your office didn't know the answer. When you test people in the district, is that test data, positive test data, shared with first responders, with either the fire or police officers, so that they know when they're going to respond at an address that there may be somebody positive there?
Yes. Yeah, yes, and we also have the ability through the health information exchange that if they had a patient transport that subsequently becomes positive, they can access that information as well.
So how many government agencies is that shared with? If somebody in the district tests positive, how many agencies do you share that information with? And do you share it with the out-of-state people you're testing? If somebody tests, a Maryland resident tests positive, do you share that with first responders in that city?
It is accessible through the district's health information exchange. So fire and EMS accesses the information through the district's health information exchange. So I'm not sure how to answer your question when you say, do I share it with other agencies, et cetera? So I don't understand that part of the question.
Well, who has access? I mean, and I'm not sure that the public knows that their test data is being shared outside of them and their medical professionals.
So members of the public who are in the district's health information exchange consent to share their information with healthcare providers in the health information exchange. So fire and EMS is a healthcare provider. So it is not like we're sharing your information with Public Works and we're sharing your information with CFSA. The MPD is not a healthcare provider.
So you don't share it with MPD?
I don't share it with anyone.
The district does not share it.
So I want to be clear. The Department of Health is not sharing the information.
Mark, I think what Dr. Nesbitt has said is that there's an information exchange that healthcare providers have access to, and fire and EMS is one. But let me be clear. They have protocols about responding to 911 calls. So they are donning protective equipment on calls. So they are protected. Yes, Martin.
All right, two quick ones. One kind of looking forward, getting to phase 2. It says in the Reopen DC Advisory Group report that you would get there when there's only localized transmission. Dr. Nesbitt, is there a definition for what that means? Do you know what it looks like when it comes across your desk? Just kind of talk through that. And then just to make clear, is there anything that could happen that would suddenly force DC back to, I guess, phase 0 or close in full again?
I would start by saying, as I said earlier, that we can turn up our lifting of restrictions up and down. So I think a more likely scenario, if the health data required it, that we could turn down some activities or turn them up throughout the phases. And we will continue to report that data and post additional metrics moving through the phases at a later time, probably Friday. Yes.
How are faith institutions treated in phase 1?
I can't hear you.
How are faith institutions treated in phase 1?
What institutions?
Faith institutions, yeah.
They are continue to be limited with the large gatherings limitation of 10 or fewer, or less than 10.
And Mayor Bowser, what did you learn from those first weeks of the pandemic in March? And what lessons from those first weeks are you applying now to the phase 1 of recovery?
Oh, I've learned a lot. That's a big question.
It was last time the city wasn't in this kind of businesses all closed, everyone's staying at home kind of posture. Like, are there any mistakes that you made then, or is there any changes that you would have made back in that period back then in March that you want to make?
I mean, I think there will be time for that discussion sometime later, Bennett. Yes. Anything else? That's it? All right. Thank you, everybody.
We now return to our previously scheduled program, already in progress.